Again, we'll
Yeah. Sure.
start.
Sure. So, hello everyone, and welcome to the session. Now, this we have reached the part of the thorax. So, in today's session, we are going to start with the part of the thorax over here, right? So, this session we are going to cover up this is the first session of thorax. So, in this first session, we are going to cover up basically the thoracic wall, or you can say the thoracic cage over here, right? I welcome all of you. I'm Dr. Ankith, and we are to this Oracle Master Live series. And we have different features of Auricle. One of this is the live classes. Then we have recorded classes, MCQs, and notes as well. And you can also use the code. Code is Ankit20 for different subscriptions. Subscriptions are there from basic course from 3 months. We have advanced course up till the or mentorship plans up till the 12 months, right? Okay, so let's start the session over here. So we are starting the thoracic cage over here, or the thorax first session. Let's begin now. So to begin with, start with the sternum over here. Now, you all should know that thorax is the area of the body or the area of the trunk that lies between the neck and the abdomen. Okay, so the upper part is the inlet of thorax, that is at the base of neck, and the lower part of thorax is basically where the diaphragm is separating it from the abdomen. Okay, so this is the thorax part, and main content or the main bones over here we all are aware of are the rib cage. So we have 12 pair of ribs on both the sides. The sternum lies anteriorly, as you will see, and the vertebrae, the 12 thoracic vertebrae, they lie posteriorly. So this is a basic structure. Let us deal one by one, and we see the images as well. So to begin with the sternum, sternum, as you all know, is a flat bone. Okay, it comes in the category of the flat bone that lies in the front of chest. Okay, and it has a sort of T shape, we can say, but more importantly, you can just start with answering in the exam. That's a flat bone. Very easy to identify it. If you look at from straightforwards, and you will have some one part like this, then you have some body part of the sternum, and below you have this part. So basically, sternum will be having 3 parts as written in the second line: a manubrium, a body, and a xiphoid process. This part is known as the manubrium. This part over here is the body of sternum, and below this part is the xiphoid process. This is the xiphoid process of the sternum, right? On the sides of the sternum, you will also encounter a lot of these facets over here, which are there for the articulation of the costal cartilages. This way you can easily identify the sternum. So there's no problem, big deal in identifying the bone sternum. So you have to start with the writing, there's 3 parts: the manubrium, the body, and the xiphoid process. Then quick words about each part. Manubrium, as we said, it is lying the superior aspect. Okay, it's like superior aspect over here, and it has a jugular notch. Now, what is a jugular notch? Jugular notch is what we can actually feel also. This superior border of the manubrium, this part is known as a jugular notch. So it is known as jugular. Also, it is known as the suprasternal notch. So its other name is what? Other name is suprasternal notch. This you can feel over here, right? As you go down in front of the neck, the bony resistance which you feel first, right? At the upper border, you can feel this part. This is the suprasternal notch. Suprasternal notch. Other thing of the sternum is that in the manubrium, this sternoclavicular joint. Now, where does the clavicle actually articulate? Here you can understand that here you have the clavicle which are articulating with the sternum. These bones are both the bones, these are clavicle. And this joint is therefore sternoclavicular joint. If you go through the previous lectures in the general anatomy, the first one, beginning one, we have discussed that this is which type of joint. The sternoclavicular joint actually is the saddle variety of synovial. It is a saddle variety of synovial. Okay, let's move forward. So a sternoclavicular joint is present over there. And also remember, the first rib is the one which is going to articulate with the manubrium. So below the clavicle, over here you have the first rib cartilage. And below you will obviously have the second rib cartilage, but second rib will be attached at the sternal notch over here. This is known as the sternal angle, or can also call it a sternal angle of Louis, right? So this is a junction of manubrium and the body of sternum. At this junction, the second rib costal cartilage actually joins. We'll see in the images as well, and that is quite an important landmark. Okay, so now coming to the body of sternum. Body of sternum is for articulating from third to sixth rib. So remember that this sternal angle over here, the junction of manubrium and body, here you have the second rib, then third, fourth, fifth, and sixth. They're attached on the side of the body of the sternum. That is what they written over here. And xiphoid process is a smaller part. And from here you have this 7th and below. See, 8th, 9th, 10th, all these ribs, they don't attach directly to the sternum. They will attach indirectly and via the costal cartilages. And what is they forming over here? That is what is known as the your costal margin. This is known as the costal margin over here. We'll see further on. Basically, to start with the sternum, start with the flat bone, 3 parts, and tell the attachments onto the sternum. Mainly attachments you have to give are the upper 6, 7 ribs and the clavicle over here. These are the major attachments. You talk of the sternum. Okay, now coming to the ribs over here, let me show you a diagram. Actually, this is the diagram of the sternum. Here you can look at the sternum and you'll understand it better. This is what we have just dealt with. This is the our jugular or the suprasternal notch over here. Okay, let me just zoom it a bit. And you can see the manubrium, the body, and the xiphoid part. And at the manubrium, you can see this clavicle that is articulating with the manubrium. And you can see this is the first rib over here. And look at the second rib where it is attached. Second rib is attached at the sternal angle. Okay, sternal angle where the manubrium and the body they meet. This is a transverse ridge, which you can feel. Actually, you can feel this part very easily. This part, right, with your finger, suprasternal notch. Then if you go below for say 3-4 centimeters below, around 3 to 4 centimeters, you'll again feel a transverse ridge. That is the sternal angle. And the rib or the cartilage that is attached at the sternal angle, and that is your second overhead. This is the most defining part. Why? Because to help you in counting of ribs. This helps what in counting of ribs, that you have to understand. Okay, so second over there. Then as you go down, you'll see the third, fourth, fifth, sixth, and seventh. Okay, they are joining over here. But now do remember always that the ribs don't articulate directly. It is the costal cartilages. So you have the costal cartilages that are going to articulate directly to the sternum. So ribs will end a little bit laterally over here. And from here, you have the costal cartilages and they attach to the sternum. Okay, that's the whole point over here. So this is the sternum over here. Now let us see more of what we are discussing. Okay, here we come down ribs. Now coming to the ribs. Ribs, you all must be knowing that there are 12 pair of ribs. 12 pair of ribs. Okay. Now see what happens is the ribs are divided into typical and atypical ribs. The atypical ribs, we'll see the differences also. But remember, atypical ribs are basically the upper 2 ribs, and the lower 3 ribs around 10th, 11th, and 12th. These are somewhat different from a typical rib. Typical rib is normally 3rd to 9th ribs. They are typical ribs. Now, we'll understand difference. Now, coming to the ribs over here. Ribs head. See what? Let me just show you an image first of all. Then we come to the theory part. Let us look at a rib over here. Okay, over here. Yeah, this part you can understand from here. Okay. Now look at this particular diagram over here, and you see in the anterior end. Why? Because this is the sternal end over here. Okay, so anteriorly you have the sternal end. Then ribs are going back, and they form the main part that is known as body. Then this shaft of the rib, this body is basically nothing but the shaft of the rib. This shaft of the rib, it suddenly curves posterior medially, and that part is known as angle of the rib. Now, as it suddenly curves, therefore, this angle part is the most common site for fracture of the rib because there is certain curvature over here. Then as it goes posteriorly, it will attach to the vertebrae over here because anteriorly is sternum, and then posteriorly, obviously, it attached to vertebrae. Now, this part is known as the head of the rib. It normally has 2 facets over here, a typical rib. So head of the rib has 2 facets. And just if you move away from the head, then the next part you get is the neck of the rib. That is a constricted part. And then you get a tubercle of the rib. Now these things, head, neck, tubercle, all of these, what are they doing? They are basically articulating with the vertebrae over here. So head articulates mainly with the, you can say, the body of the vertebrae, while this tubercle over here, that is articulating with the transverse process. Let me write over here the name of joints as well. So when the rib will articulate the body of the vertebrae, we call it as costovertebral joint. Understand this. And when the rib is articulating with the transverse process of vertebrae through the tubercle, that is known as costotransverse joint. That is known as costotransverse joint. Remember this difference. And both of them are basically a type of synovial. Okay, they are type of plain synovial joint. So they are type of plain synovial joint. Okay, do understand this small part as well. Okay, so costovertebral, costotransverse. Now let's come back to a discussion of the ribs above. So yeah, here we are discussing the ribs. So head has 2 facets. One articulate the corresponding vertebrae and the other articulates with the above vertebrae. So these two facets of the head, they articulate basically with the vertebrae, one above and one of the same level. Neck is the connector of the body. Body is flat and curved. Now, there's a very important thing over here. What is that? If you look at the shaft of the rib, shaft is what we said in the body of the rib. Now, see, imagine that if I make sort of rib over here, see, this is the anterior end, and this is the shaft of the rib that goes behind, forms the neck and the head over here. So this is the shaft of the rib. If you look on the inner side of it, the lower border is sharp. Okay, the lower border over here is sharp. And on the inner aspect, it has a groove that is known as costal groove. What is that known as? That is known as costal groove. So which border is sharp? It is the inferior border that is sharp and deep to inferior border. Or you can say on the inner surface, on the medial surface of the shaft, there is a groove that is known as the costal groove. So the internal surface of the shaft has a groove. For what? For passage of neurovascular bundles. What happens is, you can remember the mnemonic is vein, V-A-N, vein, artery, and nerve. So from top to bottom on the inner aspect of the lower border of rib, I repeat again, listen carefully. From top to bottom on the inner surface of the lower border of the rib, you have the arrangement of structures going like this: intercostal vein, intercostal artery, and intercostal nerve. Therefore, what is said is, when you're doing any instrumentation, okay, between the ribs, that is the intercostal spaces, don't put your needle at the lower border, else you might damage, there are chances of damaging these neurovascular bundles. Because remember, this point is clinically very important. Always stress on the clinical point more. Why? Because in theory, you have to write clinical anatomy. In Viva, you have to answers. And once you pass all of this, and it's going to help in your PG exams. If not, then in your life as a career option also, you are becoming a doctor. These clinical aspects are the most important. Fair enough. So we have starting to look at the ribs. So had we have look at the atypical ribs. Atypical ribs are told in the beginning that the upper two and the lower three ribs, they are atypical. There's slight differences over here. And just go through this, that what are the slight differences? Let us see some differences. See, rib one will only have one facet because there is no vertebrae, there is no thoracic vertebrae above T1, right? So it has only one facet and it has a superior surface, has groove for subclavian vessels. Remember subclavian vessels, the neck. Subclavian, the name is why, because they're going below the clavicle, but they're above the first rib. Here you can palpate the subclavian ribs. We do a deep palpation on the medial aspect of the clavicle, deep to the clavicle, a deep palpation. There you might encounter the pulsations of the subclavian artery. Okay. Rib 2 has a rough anterior surface where serratus anterior muscle originates. That's the difference. Rib 10 has only one facet. Rib 11, 12 have no facets because they are floating ribs, right? So articulation of rib anteriorly, look at this point. This point is quite important, that ribs 1 to 7, they directly go to sternum. And this is the reason I'm giving you additional points. They are known as vertebrosternal ribs. What are they known as? They are known as vertebrosternal ribs. Ribs 1 to 7, because they go from vertebrae to sternum. Ribs 8 to 10, right? They will form the costal margin. They form the costal margin. So they are going from vertebrae behind, but they don't reach the sternum anteriorly. Therefore, the other name of them is vertebrochondral ribs. Vertebrochondral ribs, which ribs 8 to 10 ribs. And rib 11, 12 are floating ribs. So they are attached to vertebrae, T11, T12, but anteriorly there is no attachment of these ribs. Okay, anterior end is you can say free over there. Therefore, rib 11th and 12th, they are simply known as vertebral ribs. They are simply known as vertebral ribs. So remember these basics differences. Okay, now let's see below. So costotransverse, costovertebral joint we have seen. Now what are the various ligaments in the thoracic region? Ligaments you will see more better while doing a anatomy, looking at the anatomy of the vertebrae. But understand over here, a few ligaments, its name should be at your tip. There are what anterior and posterior longitudinal ligaments. Okay, then you have ligamentum flavum, interspinous, and supraspinous ligament. At least go through their names. You should be knowing it. I'm looking at a diagram of the vertebrae. If not, okay, let me show you over here. What happens is that if you look at a lateral view, which view lateral view? Suppose I try to show you a right lateral view, right side lateral view. Okay, right side lateral view. So anteriorly, what we have? Anteriorly, we have the vertebral body. Okay, then we have the pedicles, then we have the laminas, and then we have the spinous process like this. Just imagine over here. This is a right lateral view. So I'm trying to make this as the anterior part, that is the posterior part. What you guys palpate at the back is actually the spines of the vertebrae. So This is the body over here. That is a pedicle. That is lamina. This is a spinous process. And what is going laterally over here? These are the, imagine the transverse process, right? We all are aware of this being the what? This being the transverse process. Transverse process. Now let's look at the ligaments. Just understand the ligaments. This is the anterior longitudinal ligament, which is going above and also going down. Anterior longitudinal ligament. It is connected to the anterior surface of the body of vertebrae. Now, second, the yellow color over here, this will be the posterior longitudinal ligament. Okay, so understand the position. They are going above and below. So anterior posterior longitudinal ligaments that run in the length of vertebral column, covering the vertebral bodies, understand, and the disc between the body. These are the two longitudinal ligaments. Then comes ligamentum flavum. I'm showing with say green color over here. Now this is the lamina part, so it covers the front of the lamina and it goes from top to bottom. It is quite elastic. That is known as ligamentum flavum. Okay, let us write also their names over here. This is ALL, anterior longitudinal ligament. That is PLL, posterior longitudinal ligament. And this is ligamentum flavum. Okay. Then we have interspinous and supraspinous ligament. Now see what happens is the basic difference over here is that if you look over here, let me change the color a bit. Okay. The ligament which is connecting the spinous process, okay, that will be the interspinous ligament. And lastly, the ligament that is connecting the spines, that will be the supraspinous ligament, the tip of the spines. That is the basic difference. So this over here will be the interspinous ligament. Now you might think, why is that important? While doing lumbar puncture, guys, these ligaments are very important. Any surgeries around the vertebrae, spinal cord, a lot of things happen in the vertebrae. A lot of disc problems you already know. A lot of stress fractures that can occur over there. A lot of tumors can arise from there. The anatomy of vertebrae is of paramount importance. Okay, so this over here is the interspinous and this is the supraspinous ligament. This is the supraspinous ligament. Basic differences. Okay, so anterior longitudinal, post longitudinal, 5 ligaments are there, which you worth noting. There are many more ligaments. Don't worry about them. Anterior post longitudinal ligaments, flavum, supra and interspinous ligament. Okay, let's move ahead. This is a rib cage. Okay, I hope you can understand this. And now come to the costal cartilages. Costal cartilages we already are aware. Basically, these are the hyaline type of cartilages. Which type of hyaline type of cartilages? So they are present in the anterior aspect of the ribs to provide a medial extension. First 7 pairs are connected to the sternum, as I told, vertebrosternal ribs. 8th to 10th articulate with the lower border. They are a part of the vertebrochondral ribs, and 11th and 12th they end over there. Costal cartilage has 2 surfaces, anterior posterior surfaces. No need to go through that point in detail. That is not frequently asked. Borders, you can obviously say upper superior border, inferior border. Above one is concave, lower one is convex. They obviously see what happens is, let me tell you over here, what if they talk of the attachment, suppose these parts over here. What you would understand is, you have to understand what are the various muscles which are attached to the ribs. Now, look at the rib cage, human rib cage anatomy. As is written over here, this is a human rib cage anatomy over here. Now, this is the lateral view. You can see the anterior and posterior aspect. And this is the frontal view. That is the anterior view. This is the anterior. This is the anterior view. And that is the lateral view. This is the lateral view over here. Now see, if say this is, let's start the counting. This is say the rib number 1 over here. That is say rib number 2. And this therefore will be rib number 3 over here. Likewise, there will be rib number 4 over here. And likewise. What actually happens is, if you look carefully, you will realize that between this rib 3 and 4, can you identify the space? The space is between rib 3 and 4. And this space between rib 3 and 4 will be known as which space? This will be known as third intercostal space. So space between third and fourth rib. It is between third and fourth rib. Okay, between third and fourth rib, and that is known as third intercostal space. Just a second. Okay. So you have to understand that what are the various structures that lie in the intercostal spaces, and do remember that it is basically what? It is basically your is basically the intercostal muscles and the muscles which are in the chest wall. Okay, so here what will happen is you have basically what? You have basically the intercostal muscles over here. Okay, so these intercostal muscles, they are forming the bulk of the intercostal spaces. Do remember this part. So those will be attached to the costal cartilages. These intercostal spaces, the contents of this, the intercostal muscles will be there. Muscles like pectoralis major will be there. We saw in the upper limb, like serratus anterior will be there. On the lateral side, like anti-abdominal wall muscles will be there. They are attached to the costal cartilages, plus some of the other muscles we'll see. So this is about the costal cartilages. Here is a diagram showing you the cut end of the sternum. Now look at the vertebral column now. Now let us look at the vertebral column. Vertebral column is the axial skeleton of the humans. Okay, we all know. Now there are 33 vertebrae, and obviously some of them fuse, and they in adults they come out. The numbers come out. We finally around 26 vertebrae after fusion. After fusion, okay, in vertebrae there are 26 in adults after fusion. Out of them, understand, cervical we have 7, thorax we have 12, lumbar we have 5. Okay, so it is 5 plus 7, 19 plus 5, 24. And sacrum are fused one, 24, 25, and bit of coccyx. We can say they are fused sort of. There are around 26 fused vertebrae fused. Now, vertebral column has 4 main functions. This you can answer in Viva as well as in your theory exam. Protection, as we all know, it will protect the spinal cord, support, it is carrying the weight of body, forms the axis and movement, right? So this PSAM you can remember as a mnemonic, PSAM or SPM as a subject, right? We have a subject in a medicine known as SPM or PSM. We also say PSM, so protection, support, and movement. In movement, you can write as X over. So in vertebral column, what we have vertebral body. Now these are the parts of vertebral body. You can see this red color over here. This red color is a vertebral body over here, and this blue color is a vertebral arch. Here, what we are seeing actually is this is the anterior aspect, that is a posterior aspect over here. So this thing is what we are discussing, that BPL you can use this as a mnemonic. B, P and L. What is BPL? B is your body, P refers to the pedicle, and L refers to the lamina. L refers to the lamina. So BPL, you can remember that from going from anterior to posterior. And these two we already are aware of. This is a transverse process, that is a spinous process over here. So the body, you can say the superior inferior aspects of the body are lined by hyaline cartilage. So see, we have an intervertebral disc over there. If you say there's one body above and one body below, see what is joining both of them? Both of them are joined over here by the intervertebral disc. And this intervertebral disc, if you remember, this intervertebral disc is a type of which joint? It's a type of secondary cartilaginous joint because it lies in the midline. It is secondary cartilaginous joint. While the other joints between the vertebrae are between the facets, those are synovial joints. Vertebrae is not only connected, the two adjacent vertebrae are not only connected by the disc, they are also facet joints, superior and inferior. There are articular facets over there, they form the facet joints. Those are basically types of synovial joints over there. Okay. So let us see more. So this is the parts of vertebrae and a couple of joints over here. So vertebral body will form the anterior part, vertebral arch form the lateral and posterior part. And you see what happens is that you can imagine the one more vertebrae over this and one more vertebrae under this. So what actually happens is all of this over here, all of this area over here, this forms the vertebral whole canal. What will be the content of this whole area? Obviously, it's going to be the spinal cord. There's going to be spinal cord over here. But not just that, it will be covered with the meninges. There are lots of meninges over there. Plus, there are going to be a lot of vessels over there, right? So, cord, meninges, and vessels around it, they will all be a part of this vertebral canal over here. That is what they're describing over here. That the foramina of all the vertebrae line up to form the vertebral canal, which encloses the spinal cord. Fair enough, yeah. So these are the parts over here. You can see the anterior, and there's a lateral view over here, beautifully depicted a view over here. There's a lateral view over here. Try to understand this. This blue color is the body. Okay. And as I said, BPL, don't forget the BPL over here. So this blue color is the body, that is the P for pedicle, and that is the L for lamina. And between pedicle and lamina, we have the T for transverse process. Behind is the green color S for spinous process. And you can imagine that this is the superior and this will be the inferior, sorry, right? So this will be the inferior articular facet, this will be the superior articular facet, and they are forming a joint over there. So these joints over here, they are basically known as facet joints. Facet, F-A-C-E-T, facet joints, and they are basically synovial. While these joints over here, you have the intervertebral disc over here, they are secondary cartilaginous. Okay, but try to understand this. Look at this image as well. Look at this image as well, right? Color coding is beautiful for your better understanding. So normally what we see over is a herniation, right? We have heard a lot of it about the herniation aspects. So herniation of the disc then can occur, and with the nucleus pulposus ruptures, breaking through the annulus fibrosus. Now do remember a basic thing that in an intervertebral disc, there are two things. One is the outer part is sort of rough, and that forms the annulus fibrosus, forms a ring of fibrous cartilage known as annulus fibrosus. While the inner part over here is sort of jelly, and that is known as the nucleus pulposus. That is known as nucleus pulposus. So in disc herniation, what happens is when there's a lot of stress on the body of the vertebrae, this part, this nucleus pulposus, it tries to come out. Normally posteriorly, laterally it can come out. It can come out posteriorly also, laterally also. But most commonly, or anterior also, it may herniate. But most commonly, this herniates mostly in the posterior lateral direction. Okay, as it's written also, where the rupture usually occurs in the posterior lateral direction after the nucleus pulposus might compress or irritate the spinal nerve. So that is quite an important clinical anatomy over here. Okay, you have to understand few words. So look at the basic anatomy of the vertebrae. Try to decipher the ligaments as we discussed earlier. Longitudinal ligaments, supra and intraspinous, and ligamentum flavum. Parts of vertebrae, what is a vertebral canal, and types of joints you can answer over there. And finally, applied aspect, because all that boils down to the applied aspect. This is what you're going to diagnose and see in MRIs and try to correct it by medically or surgically. Now let's come to the different parts of vertebrae, or the whole vertebral column. As I said, you have cervical 7, you have 12, thoracic and all. So coming to the cervical vertebrae, there are special parts of the vertebrae over here. So cervical vertebrae is basically identified by this transverse foramina. If one thing you have to choose, that is transverse foramina. Meaning by what? Meaning by the transverse process of the cervical vertebrae, they have a foramen inside them. And that is known as foramina transversarium. That is known as foramina transversarium. In Viva, you can be asked that what passes through it. Normally, it is the vertebral vessels. Vertebral vessels pass through it. And if the examiner, if you are able to answer all of this, the examiner wants to ask more. The examiner might ask you, okay, vertebral artery is a branch of which artery? Then you have to answer it's a branch of which artery? Try to pause and answer. It's a branch of subclavian artery. It's a branch of subclavian artery. Do remember this. So cervical vertebrae, one thing, if I may say, it's a foramen transversarium. That is most important. Or see, only the cervical vertebrae transverse process will have a foramen. No other vertebrae transverse processes have any foramen. So that is one point. Okay, here you can see. Let me point out. This over, that is a transverse foramen, right? Now this vertebrae, if you see with a projecting part, that is the C2 or the axis vertebrae. And this projecting part is known as odontoid process or the dens of axis. We normally call it as dens of axis. Okay. Also, secondly, if you see a vertebrae which has no body, then this vertebrae is your atlas or C1. Okay. That is known as atlas vertebrae or C1 vertebrae. It is like a ring shape. Only lateral facets you have. What for articulation with the occipital bone? Basically, above C1, what will we have? We have the skull. And which bone on the skull? Occipital bone. So therefore, C1 over here, it is known as the atlas vertebrae, and above it you have the you can say the atlanto-occipital joint, the joint which is formed by these faces over here. If you can see the transverse, these faces over here, like we'll show you like this, right? They form which joint? They form the atlanto-occipital joint. They form the atlanto-occipital joint. So the vertebrae with the no body is the atlas. The vertebrae with the projecting part going superiorly, that is the dens. And this is the dens of C2, which you can see over here. This is the dens of C2. So atlanto-occipital joint is what we are discussing. Okay, so remember this. Now coming to the thoracic vertebrae have a special feature. And that special feature is that the ribs are coming and articulating with them. Normally, cervical lumbar vertebrae, they don't have any ribs attached to them. Sometimes there can be pathology known as a cervical rib that can be attached to the C7. Sometimes it's a pathology. But normally, it is only the thoracic vertebrae which have the attachment to the for the ribs over there, right? So therefore, you have this basically in the feature of the thoracic vertebrae, that will be the costal facets for articulation with the shaft of the rib. That is the main feature. Rest you can just go through. They have spinous process. Each will have a demi facet for articulating with all of that. Do remember, costal facets are the feature. Lumbar vertebrae, they have very big bodies. Okay, they have very large vertebral bodies which are kidney shaped. They lack the characteristic feature of other vertebrates, like their transverse process will have no foramens, nor will there be any faces or demi-faces in the lumbar vertebrae. But the feature is that they have a very huge, very big body. Sometimes it becomes complicated anatomy to understand all of this. What actually happens is, let me tell you a practical point of view is, let's see, cervical vertebrae is at the top. Okay, you have cervical vertebrae. Then as you're going down and down, you have thoracic vertebrae. As you're going down and down, now you have lumbar vertebrae. You have lumbar vertebrae. And finally, you have this upper end of the sacrum over here. Just imagine for a second all of this. If this area, understand this is the L for lumbar. This area say thorax over here. And this upper part says cervical over here. Now see what is happening is that, and when we looked at the function of the vertebral column, it was protection, it was support, it was exertion, it was movement. So protection to the spinal cord, support to the whole body, and movement and all access. So it is supporting the weight of the whole body. So actually what happens is that as you are going from above to below, superior to inferior, more and more weight is being placed over the vertebral column. Therefore, the size of the vertebral body increases as you go from cervical to thorax to lumbar to sacrum. Then what finally happens is that from the sacrum, the weight will be transmitted to the iliac via a joint over here that is known as sacroiliac joint. So here you have a joint known as sacroiliac joint. So now the weight will be transmitted to the hip bone. From there, go to the lower limb. This is how the body. Sacrum, as I told you, is a collection of 5 fused vertebrae. Coccyx is small, it's also known as a tailbone. Now coming to the joints and ligaments, see, you can just go through it, though we have discussed it. The vertebrae articulate each other via joints between their bodies and articular facets. I told you between the bodies is intervertebral disc. Between facets, we have a facet joints. Okay, left and right is superior articular facets, inferior articular facets, body via the disc that we have seen already. Spine anatomy is this. You can give them with different color coding. If they show you this sort of this diagram, you can make some cervical vertebrae, thoracic as well as the lumbar vertebrae over here. Not a big problem if you understand all of this. Spine anatomy, another diagram over here. You can just draw this now. Other question that might come in your exams or in your future exams are the curvatures of the vertebrae. Okay, curvatures are important. I will just take 1 minute over here as well. See, curvature says that if you are looking at an anterior view, it looks like a straight vertebral column going down. But if you look at a lateral view here is the anterior aspect, this is the posterior aspect. You see some curvatures. Now, understand 2 things over here, that the questions which have come, they are registered questions. One is the primary curvatures and other thing known as is the secondary curvatures. Okay, understand this. Primary curvatures are the curvatures which are present since birth. Since birth they are present. So if you look at a gynae, if you look at a antenatal ultrasound and all, you'll see there's a flexed attitude of the baby, flexed attitude of the baby. So normally the baby has a flexed attitude, and when the baby is born, the thoracic and your say sacral or the pelvic part, it is bent anteriorly only. They are known as primary curvatures. So if you look over here, then this area, the thoracic vertebrae, and you can say this sacrum and coccyx, this vertebrae, they are having the primary curvatures. Keep on understanding more. Now what happens is the child, when child is born, and after a few months, they start to hold the neck. Then after a few months, say 8th or 9th month, they will start to crawl. So these curvatures in the cervical and the lumbar vertebrae, they are known as secondary curvatures. Secondary. Okay, secondary curvatures, we have the which vertebrae? We have the cervical area and the lumbar area. So if you look at the cervical lumbar, how are they? Anteriorly, they are what? Anteriorly, they are convex. And posteriorly, they are concave. And opposite goes for the primary curvature. Remember this differentiation between the primary and secondary curvatures in the vertebral column. Okay, that question also comes a lot. Now coming to the joints of thorax, though we have done a bit, but let us do that again. So there are different joints. Thoracic spine joints can be limited to thoracic spine and those present. Joints to vertebral column are between the vertebral bodies. As we already said that these are known as your intervertebral disc and they are type of secondary cartilaginous. Then between vertebral arches, we discussed they are synovial facet joints. Okay. Joint is specific. So you have costovertebral and you have costotransverse joints. Luckily, we have this whole table. I want you guys to take a screenshot of this. Just read it 3-4 times. Read 3-4 times. The joint type is given. Okay, joint. So name of joint and the joint type is given. That is most important. What is this joint? Basically, articulation that is given. Now, these three things are most important. But coming to the applied aspect, do have a look at the comments as well. Okay, that is must know. Why? Even if it is not asked in your first year, guys, even if not asked in first year, it is quite a famous question for your PG exams. If for PG exams, you need PG INR or even FMG and all, this is quite a famous question. Types of joints in the thoracic joint, articulation to define the joint, and some comments, some practical aspect over there. Fair enough. Let's move on to the next topic, that is the wall of thorax. So we have seen this thoracic cage, main bones over here. Now let's come to the wall of thorax. So thoracic wall consists of bony thoracic cage and muscles. So we add over here is the muscle part. So it will have the intercostal muscles and just supplied by intercostal nerves and arteries. We'll discuss that. So thoracic wall to begin with. Thoracic wall, as it's part of, say, if you start to do a dissection, what do you encounter? You encounter the skin, superficial fascia, and a deep fascia. The deep fascia over there is ill-defined, but basically it is the one that is just a second. Okay. So we have skin, superficial fascia, deep fascia, and muscles. So deep fascia is ill-defined, but basically it is a fascia that is covering what? That is covering the pectoralis major muscles. They are known as pectoral fascia. They are known as pectoral fascia. So these are different muscles which are attached onto the thoracic cage. It is not just the intercostal muscles, remember. So you get a lot of muscles going to the upper limb or the abdomen or the back. They are all attached to the rib cage. So do remember, it is not just intercostal muscles. You have a lot of muscles going to the upper limb, majorly being pectoralis major, serratus anterior. These major muscles, because they are physically also important. Okay, and as well as latissimus dorsi. The rhomboids also. Abdomen, you have anti-abdominal wall muscles, and behind you have the rectus spinae group, mainly the sectospinous. Now, here's a diagram to show you the intercostal spaces, the intercostal muscles. You can very well see these ribs over here. I'm just writing RR, the ribs, and this is between them, the intercostal spaces. And if you go through them in detail, they are the intercostal muscles. Now, there are 3 layers of intercostal muscles from outside to inside. If you move or if you do a dissection, most outside is external intercostal muscle. Deep to it, you have an internal intercostal muscle, number 2 over here, as you can see. And third one will be the innermost intercostal muscle. Third one over here will be the innermost intercostal muscle over here. Okay, 3 layers of muscles over there. External intercostal, internal, and innermost intercostal muscles. Okay. So, and as we have discussed the costal group, now look over here that this thing over here is the inferior border of the rib. Okay. And deep to it, can you see this area? This area actually is nothing but the area for the costal groove. So this is our costal groove over here, which are having, can you see this blue, red, and yellow color? So I told you the mnemonic vein. Vein is blue, artery is red, nerve is yellow. So intercostal vein, intercostal artery, intercostal nerve, they are lying deep on the inner aspect of the lower border of the rib. Okay, this thing do remember about the intercostal muscles. Now coming to thoracic wall proper. So intercostal spaces are gaps between the ribs, as we already have seen that they are defined as the gaps between the ribs. Now see, do remember one point that anteriorly there are 9 spaces and posteriorly there are 11 spaces. The difference over here is, the reason is, we all know that anteriorly only 10 ribs are there. So between them we have 9 intercostal spaces. But if you go posteriorly, you will have 12 ribs and between them you have 11 intercostal spaces. So anteriorly we have 9 spaces and behind we have 11 spaces. Do remember that. So muscles in the intercostal space, this we already have seen that they have external intercostal, internal, and innermost intercostal. Now, this innermost intercostal or transverse thoracis is divided into these 3 muscles. Remember their names. Their names are subcostalis, intercostalis intimi, and sternocostalis. The subcostalis lies posteriorly, sternocostalis lies anteriorly, and this lies somewhere in the middle. or you can say in the lateral aspect, in the lateral aspect. So remember the name subcostalis, okay, subcostal behind, sternum is anterior, so sternocostal is more anteriorly, and intercostal is intima. Intima is sort of innermost intercostal. It is also known as transverse thoracic. So innermost intercostal can also call it as transverse thoracic muscle. It's a group of muscles, three muscles. Okay, muscles and their attachment points are being given over here. I would ask you to take a screenshot and just go through it. Okay, revise what these are specific points. Okay, read them 3-4 times and try to see them in the image and things will be clearer. Direction is very simple. We will see an image over it. If you insert your hand into the pocket of your jacket, suppose it's a winter, you are wearing a jacket. So once you insert your hand into the jacket, just like the direction of the external oblique muscle in abdomen, that will be the direction of the external intercostal muscle. So direction over here is external intercostal fibers. They run downward, forward, and medially. Okay, like the pocket of your trousers or pocket of your jacket if you insert your hand. Perpendicular to it will be the internal intercostal. It will lie perpendicular, just like your internal oblique muscle in abdomen. And transverse thoracic muscle have a direction similar to that of internal. So they both will be parallel. So these both, they normally lie parallel to each other. They are sort of parallel. And these two muscles, they normally lie perpendicular to each other. That is the whole point. Now let us see the images. Diagrams you can obviously make at your own convenience. But see, if you know the theory, you can make the diagram. Please do try to make the diagram. I told it multiple times. Labeling is most important. What we are trying to convey the information to the examiner is most important. Okay, that I'm showing you the rib, I'm showing the muscle. That is the direction of muscle. This is the name of the muscle. That is most important. If you are able to understand your diagram, bad. Obviously, the other person also will understand. So that is the most important. Right? Again, the direction is shown. So, like your hands going to the front pocket, that will the external intercostal, and hands going to the back pocket, or perpendicular to it, that with the internal intercostal muscles. Okay. Now let's move on. Now come to the intercostal nerves. See, now some of you, I've seen students, they are worried about, sir, there's a new term in anatomy now, intercostal nerves. What are these? There's nothing. See, we all know about the spinal nerves, right? There are how many pair? 31 pair of spinal nerves. Okay. Out of these 31 pair, you have 12 pair of thoracic spinal nerves. Simple as that. And this is nothing. This is the same that is known as intercostal nerves. Simple as that. So we have like C1, C2, C3, C4, C5, C6, C7, C8. Okay, 31 pair if you see, cervical have 8 pair, not 7. 7 is a vertebrae, nerves are 8. Thoracic will have 12, lumbar will have 5. Okay, sacrum will again have 5 and coccyx 7. Total comes out to be around 31 pair. Out of the 31 pair, 12 pair are thoracic nerves and these 12 pair are the 12 intercostal nerves. Simple as. Simple. No, the intercostal nerves are primary rami of T1 to T11, spinal nerves. Okay, spinal nerves after the dorsal primary rami have been given off their segmental distribution. Just look at the diagram of the spinal nerve and just draw it right over here. Also, you can use this diagram. So this is the vertebrae shown posteriorly, that is the sternum shown anteriorly, and from here where the posterior ramus goes out, then you have the intercostal nerve, which is actually the ventral rami or the anterior rami. It will come and it will supply what? This nerve is going to supply right from skin up till, if I may say, parietal pleura. Yes, you heard it right, parietal pleura. So that's a huge area of supply. So how parietal pleura now, see, thing over here is, if you look at the thoracic wall proper, it starts from the skin. Then deep to skin, you have superficial fascia. Then you have some amount of, say, deep fascia as well. Okay. Then you have muscles like P major and all, but they are supplied by brachial plexus. But here you have 3 intercostal muscles. You have intercostal muscles. How many? 3 in number. Okay. After that, you have an endothoracic fascia. Which fascia? Endothoracic fascia. And deep to it, then you have a parietal pleura. Now, mind you that all of this is innervated by intercostal nerve. Therefore, we say that parietal pleura is pain sensitive, unlike the lungs and the visceral pleura, which are pain insensitive. Because these intercostal nerves are basically your somatic nerves. They convey the pain, like the same pain which you feel on the skin of the chest. Okay, that same pain will be carried by the parietal pleura as well. So right from the skin, including the muscles and the fascia, up till your parietal pleura is supplied by intercostal nerves Full stop. Okay, that is what you need to understand. Okay, let's come more. So classification we have. Classification we can easily classify. We can classify them as into typical or atypical. Typical are third to sixth because they are confined only to thoracic wall. Okay. So how many spinal nerves we had? Thoracic we had 12. Out of that 12, only four are typical intercostal nerves. Other are atypical. Atypical doesn't mean that they don't supply the intercostal spaces. Atypical will also supply the intercostal spaces, no doubt about it, but they will supply other areas as well, like upper limb, like abdomen. They will supply these areas. Okay, for example, to start with, we all know that T1 forms a part of brachial plexus. T2, it will form the intercostal brachial nerve. So T1, T2, apart from supplying the intercostal spaces, they also do go and supply the upper limb. Then from seventh and below, they will go and supply the abdominal wall. They are regarded not as a typical intercostal nerve. So typical, if they ask in a viva or maybe in a theory, you can just write typical intercostal nerves are 3 to 6, 3 to 6. Simple as that, all nerves. Okay. Okay, let's see the course. And this course is important. Intercostal nerves run in the costal groove. Let me just highlight it. And ends near the sternum. Okay. Emerge from where do they emerge? Obviously, they are coming from the vertebral foramen. They go to the intercostal space, and there they lie where between the pleura and the posterior intercostal membrane. Then do remember this, that we had three muscles in intercostal spaces. These nerves they lie between the second and the third muscle. That is between the internal and innermost. The we can say the neurovascular bundle. It runs basically between the second and third layer of muscle. First layer was external, second was internal, third was innermost. So internal is the second layer and innermost is the third layer. Okay, the nerves come out from behind, then they pass in the endothoracic fascia between the pleura and the posterior intercostal membrane. So now they're coming into the spaces. Now, once they reach the spaces, then they run in between these two muscles. And then in the form of, as we said, pierces the internal intercostal in the form of neurovascular bundle, and then they'll come out. Okay. So typical intercostal nerve give the following branches. So branches are all of this. So see how beautiful they made in tabular form for you to answer in the theory exam. Beautifully explained over here. See, presentation, as I told, a lot of time presentation is important. So branches say rami communicantes. What is this? Gives branch to sympathetic chain. Because we know that the nerves, spinal nerves, they are not pure motor or pure sensory. They are mixed. They are sensory, motor, and sympathetic. Then it gives muscular branches. What to intercostal muscles? Okay, they will supply intercostal muscles and all, right? Okay. Then they give collateral branches. Collateral branches, obviously collateral to the upper and lower nerves as well. Then they give cutaneous branches. See, because it was going from skin to pleura. It was going from skin to pleura. So therefore, they have to give cutaneous branches as well. So they are giving cutaneous branches as well. Right. So these way you can just go through the table, take a screenshot if you wish to, and then just write it in your own language. Best way is to write in a tabular form like this. That will be the best way to answer. The best presentation. This you can draw a simple diagram like this. Like, see, you can give branches like say lateral branches, you have your posterior branches, you have anterior branches, you have anterior cutaneous branches. These are some of the branches you can make. The motive of all of this, what? Motive of all of this is you need to go and innervate the skin area, you need to go and innervate the intercostal muscles area, you need to go deep and you need to go up till supply up till the parietal pleura. That is the main motive. All the branches are going to supply this thing only. That is the whole motive, right? Then obviously being a sympathetic, you have to, because do remember the sympathetic outflow also comes from T1 to L2. And this is the area for thoracic spinal nerve. So obviously it's going to give sympathetic branches as well. The sympathetic outflow for the whole body comes from T1 to L2. T1 to L2 is from T1, T2, T3 up till T12 and then L1, L2. There it's going to have a good role of it. The clinical anatomy is the clinical anatomy, no doubt about it. To start with thoracocentesis, no doubt. Just visit a respiratory medicine ward for say half an hour, 1 hour. Just visit there, see how many cases will be there. Respiratory ward, or if you have no respiratory different, then you go to medicine ward. Okay. To get a TB chest department, you will understand. Thoracocentesis is just to see. There are pleural effusion, there are hydrothorax, there are pneumothorax, obviously, is there. There's sort of malignancies which come as secondaries into these spaces. There are rib fractures. There are so many things. Okay, so for that thoracocentesis, thoracic drainage is there, thoracotomy is done, thoracostomy is done. So many things which are done over there. Just to go to it, thoracotomy, just to cut it out. Okay, make a opening. Thoracostomy, to make a whole, for the fistula and a drainage pipe is inserted. Thoracocentesis. Herpes zoster, you should know, it's one of your virus infection, latent dormant, and that comes in later age when the immunocompromised individual or when the immunity goes down. Then it's also known as, you should know, the shingles. Okay. Then your root pain. Okay. So the other thing, now this table, particularly this table, I sort of personally like this table. So just read this, right? A typical rib and a typical nerve. What is the definition of typical rib? You remember we said third to ninth rib are typical. Typical nerve is third to sixth nerve. Why the typical rib and typical nerve? Sit over here. So do go through this. Just read it out. If you wish, I will. If you want, I will just read it out. Typical rib, and the rib will have head will have two facets, neck and a tubercle with an articular and a non-articular part. Typical nerve which runs solely in its own intercostal space. Solely, it doesn't go to any other area. That is typical nerve. Now comes the last part, that is the intercostal vessels. Okay, intercostal vessels. So for that, let us use an empty space anywhere. Let us use this area. See, let me first give you an idea what we are discussing. Then we'll go through the notes as well. So intercostal nerves, we have seen. Now intercostal arteries. Okay. Anteriorly, how many spaces we had? Anteriorly, we had 9 spaces, and posteriorly, we had 11 spaces. Therefore, anteriorly, we have 9 intercostal arteries, posteriorly, we have 11 intercostal arteries. If we start to write intercostal arteries anterior, okay, anterior, then we can say anterior, okay, upper 6 and lower 3. They have different names. Upper 6 anti-intercostal arteries come from internal thoracic artery, which mind you is again a branch of subclavian. And lower 3 anterior intercostal arteries comes from musculophrenic artery. Musculophrenic artery, which is actually a branch of internal thoracic. So basically, both of them are a branch of subclavian only. So anteriorly, I repeat again, anteriorly we have 9 spaces. So anteriorly we have 9 intercostal arteries. Out of those 9 intercostal arteries, upper 6 are branches of internal thoracic, lower 3 are musculophrenic. Don't worry, you'll see it. Now, if we come to the posterior aspect, how many spaces we have posteriorly? 11. That is divided into upper 2 and lower 9. The upper two posterior intercostal arteries, they again are a branch of subclavian. Okay, so you have a superior or supreme intercostal artery, which is a branch of costocervical trunk, that is directly branch of subclavian only. Lower 9, they directly come from the descending thoracic aorta. From where do they come? They directly come from the descending thoracic aorta. You have to understand this. So lower 9 posterior intercostal arteries, they are coming from intercostal descending thoracic aorta. Coming to the venous drainage, remember, over here anteriorly, the veins over here will finally drain ultimately into brachiocephalic vein. So they will go to interthoracic vein, but finally it will drain to a brachiocephalic. Posteriorly, the major system that we'll see is the azygous system of veins. Azygous system of veins is important posteriorly. This thing, remember, anteriorly 9, 6 and 3, posteriorly 11, 2 and 9. Okay. Now we have understood this, then we can have a look at this thing over here, intercostal arteries. So each intercostal space contains of one posterior intercostal artery that you start with its collateral and two. So you have a posterior intercostal artery, some collaterals might come, and you have 2 anti-intercostal arteries. They bifurcate actually. The greater space is covered by the posterior intercostal. Here you can see in the image, try to understand anatomy with the image, anterior and posterior. Okay, so look at the aorta over here, giving off the posterior intercostal artery over here. Okay, this is the posterior intercostal artery. And then over here, look at the internal thoracic artery over here and giving off the anterior intercostal artery over here. Okay, and how they are running? How they are running at the ribs on the costal groove. Look at the costal groove over here. Now, what are these vessels? Now, you may say, sir, they are also in the upper border. Yes, but they are not the major vessels. They are the branches of it. What are they? They are the collateral branches. The major vessels are lying in the costal groove. This is the place where the major vessels will be there. Though they will give the collateral branches over here, which will run in the upper border, but their best way is to save the main branch. That is more important. Okay, now as what we have discussed already, there are 11 posterior intercostal arteries, and first and second are arise in the superior intercostal arteries, branch from subclavian. Third to 11th, they are coming from the thoracic aorta. Okay, course and relations. Okay, so course and relations can be asked, not frequently asked, but yes, just go through the course and relations and you'll understand. But basically, as I told you, neurovascular bundle. The neurovascular bundle lies where it lies between the second layer and the third layer of muscles. Okay, on the right side will be a bit longer. That's common sense, guys. The reason is that we all know that the aorta is to the left of midline. The right posterior intercostal artery will be slightly bigger than the left. Why? Because the aorta is to the left of midline. This is, imagine, black line is the midline. That is as simple as that. Okay, then they go and terminate by anastomosis. So there is also a lot of anastomosis which runs between the anterior posterior intercostal arteries. And this anastomosis is basically helpful whenever there is a aorta constriction. And that is what is also known as the coarctation of aorta. That is also known as the coarctation of aorta. Okay. So anti-intercostal arteries, now we can see that they are 9 in number, and upper 6 and lower 3, upper first to 6, and you can see upper 6 and the 7 to 9 are lower 3 over here. Terminate the costochondral junction. Okay, this images over will show you the arteries. Okay, now summary image is this. This is a summary image. I want you guys just take a screenshot of this and just read what they are saying. Remember, in this image, this is the anterior aspect and that is the posterior aspect. You can see the aorta on one side. On one side, that is normally on the left side. So you can imagine we are looking at an inferior view, right? Because this is the left side, that will be the right side. And as we said, it is an inferior view. Okay. You can see from here, the posterior intercostal arteries are coming. And from the spinal cord, you can see the nerves are coming out. And anteriorly from the internal thoracic artery, you can see the anterior intercostal arteries are coming out. And how they are ramifying the entire area. How they are ramifying the entire area, both nerve, artery, and vein. Both nerve, artery, and vein. Okay. Come to the intercostal veins. Come to the intercostal veins over here. Intercostal veins, do remember that we have a two anterior and one posterior intercostal veins. Anteriorly, I told you that they all will actually drain to internal thoracic vein. But that internal thoracic vein does not drain to subclavian. That drain into where? That drain into the brachiocephalic vein. So all of these intercostal veins, internal thoracic vein, where do they actually drain? They finally drain into brachiocephalic vein. Brachiocephalic veins, not the subclavian, not the subclavian. Posteriorly, as I said, that there is an important terminology. Posteriorly, that is known as the azygous system. So posterior intercostal veins over here, they will finally drain into the azygous system. Okay, we'll see the azygous system in a while. Internal thoracic artery, a bit of detail of it. From where does it rises? You can understand that it is lying lateral to the sternum, and internal thoracic artery therefore is used for most of your CABG surgeries, coronary artery bypass graft. So while using for CABG, that is an important applied aspect, that nowadays this internal thoracic artery is being used, some part of it is taken up to use as a graft while treating the putting a graft for the coronary arteries. And the coronary arteries get blocked and the blood is not going to the heart. Okay, so to make that flow patent, this internal thoracic artery is used as a graft over there. Okay, these are all the courses of it, relations, you can just go through it. So not that frequently asked relations, but yeah, same diagram over here. Okay, branches can be also internal thoracic. That's the last part that we'll see. Branches, to start with, you have to start with the pericardiophrenik artery. Name says pericardiophrenik, so it is supplying the pericardium and the phrenic area, that is the diaphragm area. Mediastinal branches, anterior intercostal, that we already have seen. Perforating branches, remember in upper limb we did a topic of mammary gland, the breast. There also the blood supply to the medial quadrants of the breast that came from the perforating branches of the internal thoracic artery. Okay, you can see they're supplying the breast area, right? Then finally, what happens is, see, these are the two internal thoracic artery. As they go down, they divide into this, what we call them as internal thoracic. These are musculophrenic. But here, do remember that they bifurcate, and this artery which comes down is your superior epigastric artery. It's the superior epigastric artery, as is written over here. It is a terminal branch. And it runs where? It runs deep to the rectus abdominis muscle. Okay, that will do in the abdomen part. Musculophrenic artery and all of this. Okay. Here you can see the branches of the internal thoracic artery. Summary table is this. Summary table is this, all the branches. Just wish you to take a screenshot of all of this and just read it for a while. Read it for a while. Right. So this was the session, guys, and we'll see in the next session. We'll just continue from here. Some topic is I guess veins left, and then we'll come to the pleura and the lungs part. I hope you're enjoying. Any comments, write in the comment box. And that's all for the session. See you in the next session. Thank you. Bye-bye.